Now that we've covered the basics, we proceed to the sessions on ECG in ischemic heart disease. Our first session will be chaired by Dr. Narasimhan, Director of Electrophysiology at KR Hospital, Hyderabad. Dr. Bindumati, Professor of Medicine at Ambedkar Medical College, Bangalore. And Dr. Ganesh Khandege, Professor of Medicine at AJIMS, Mangalore. Kindly occupy your designated seats. I invite our speaker for this session, Dr. Yash Lokhandwala, onto the dais to speak on ECG in ACS, how to recognize a high-risk patient. I request the chairpersons to introduce Dr. Yash Lokhandwala.
Good afternoon. It's a great pleasure to introduce Dr. Yash Lokhandwala. He is the partner in Arrhythmia Associates. He is adjunct professor in biomedical engineering, IIT Mumbai. He is also a visiting faculty in CMC Vellore, at Civil Hospital Ahmedabad and Military Hospital Pune. He is an international indexed PubMed publications are more than 140 for his. In 2001, he has been into the private practice. During this period, he has helped to set up cardiac electrophysiological programs in various institutes. All these centers have now the active electrophysiological programs and have regular arrhythmia clinic facilities. He's got personal experience for the radio frequency ablations over 10,000. We welcome you, sir, and for this lecture on the high-risk patients, how to recognize our high-risk patients. Dr. Yash Lokhandwala.
Thank you, chairpersons, respected seniors and colleagues. This is a very vast subject, and in the course of the next 20 minutes, therefore, I will just highlight on the high-risk patient of acute coronary syndrome. Before going on to the topic, I would like to acquaint you, for those who are not already aware, of the changing concepts in the definition of myocardial infarction, which were published last year as a joint task force, including experts from all over the world, but predominantly North America and Europe. Maybe this classification will become more common in years to come. The reason being that we all so far have centered around the ECG of diagnosis in a patient who has a first and spontaneous myocardial infarction. But over the years, we've had different recognition that different settings of myocardial infarction may not necessarily have the same diagnostic parameters, especially when we talk about a reinfarction, or we talk about an infarction related to thrombosis of a stent, or after a bypass surgery. And importantly, when we talk about sudden death, we know that in acute myocardial infarction, almost 1/3 of patients with the first MI are estimated to die suddenly. So therefore, all epidemiology about the mortality of acute MI is once the patients come to hospital. But now it's recognized that if you die in the community, and especially if there has been some history of chest discomfort followed by sudden death, it can be assumed to be because of an acute myocardial infarction. Myocardial ischemia is diagnosed either by the ST segment depression or T-wave inversion. But a word of caution, T inversion is quite non-specific. And therefore, if you see a symmetrical or deeply inverted T waves, it is always abnormal, but not only necessarily diagnostic of ischemia. For example, even hypertrophy could produce similar T waves, and therefore the diagnosis of ischemia has to be clinically correlated. Non-specific ST and T wave changes is a terminology that should be used as less as possible. It doesn't mean it's normal. Non-specific could vary from the absolutely benign ECG or patient to the patient who is at a risk of a major myocardial infarction. The less recognized signs in ischemia are when a previously inverted T wave becomes positive, so pseudo-normalization, or a prolongation, a transient prolongation of the QT interval. And therefore, the term instead of MI, we probably we'll start using the term of acute cardiac ischemia, because the distinction between unstable angina, pre-infarction syndrome and acute MI is increasingly getting blurred. Because if you have chest pain and enzyme changes, straight away goes into the diagnosis of acute MI, where someone else without the accessibility to the enzymes, we call it unstable angina, and therefore, instead of labeling these terms, probably we may start using the term acute cardiac ischemia. So the ECG manifestations are either ST elevation or ST depression. ST elevation by definition should be at least 1 millimeter at the J point. Now you might start thinking that if you use this definition, you'll overdiagnose MI by including a lot of benign early repolarization. To remove this overdiagnosis, there's another caveat. It has to be in at least 2 contiguous leads. That means if you're talking of an inferior wall MI, it should be in at least lead 2, 3 and AVF, at least 2 of those leads. But if you're talking of an anterior wall MI, and especially in leads V2 and V3, then it should be at least 2 millimeters. So these are important caveats. ST depression is when it is at least a millimeter, because we don't measure half a millimeter, in at least 2 contiguous leads. They may or may not be associated T wave changes, and the lead should have a predominant R wave. Ischemia is a very dynamic process, and therefore if somebody has the same ST segment day after day, it's not going to be ischemia. This slide shows the dynamicity of ischemia as relates to the ECG, showing that ECG changes precede even the pain and occur within a few seconds. You can see this example of a patient who is undergoing an angioplasty, and there is baseline ST depression in lead AVF. The right coronary artery is completely occluded abruptly, and the ST segment normalizes, the depression disappears and is replaced by ST elevation, all within the span of 10 to 15 seconds. Now, in clinical practice, this doesn't happen because you don't get abrupt and total occlusion of an artery. But it's just an extreme example to show how dynamic and rapid the ECG changes could be. The same patient, the moment the balloon is deflated, within a few seconds, the ST elevation is replaced by a normal ST segment, followed by ST depression. So to summarize the changing concepts of ACIR, that biomarkers, especially troponin, will be the central pillar, especially for the non-spontaneous myocardial infarctions, that means the non-type 1 infarctions. We'll try to restrict the term unstable angina. Maybe other imaging modalities will have an increasing role in the other types of myocardial infarction. The term recurrent MI is used 1 month after the index MI, and if it's within 1 month, it's called reinfarction. However, having said all that, in large parts of the world where it's not easy to access biomarkers, leave alone these imaging modalities, the conventional diagnosis of acute MI, that means at least 2 out of 3 symptoms, ECG and enzymes, will persist. So what do I foresee the role of the ECG, let's say, in the foreseeable decade or so? At present, the ECG is pivotal in the diagnosis of acute cardiac ischemia and will remain to be so. We know that the ECG is abnormal in more than 95% of patients with acute MI. But more important, the high-risk patient, which is the focus of this talk, can be readily identified from the ECG. And therefore, when time is muscle, in the golden hour, the ECG will remain the most important tool. In acute cardiac ischemia, usually we have a single culprit vessel, almost always. You have localizing value of the ST segment elevation and of T inversions, but ST depressions do not have a localizing value. So if we look at unstable angina, which is the high-risk patient? From the ECG, it is one who has a very fluctuant ST segments. When there is gross ST depression seen in multiple leads, when the orphan lead, I call AVR the orphan lead because it's a neglected lead, shows you ST elevation, beware. When you have the pattern of symmetrical T inversion in the precordial leads, it's a high-risk patient. And the worst is one who has a diffuse widening of the QRS occurring with the onset of chest pain. This is an example of an middle-aged man who came with recent onset typical angina and presented to the outpatient, to the emergency room by the time his angina had settled spontaneously and the ECG was completely normal. He was admitted for observation, kept on a monitor, and this is a continuous tracing from the monitor showing that he again, within a few minutes of admission, when he got chest pain, his QRS, his ST segments did depress, but along with that, the QRS complex showed a diffuse widening, not conforming to any typical bundle branch block. As I told you, widening of the QRS is not a common sign, but it's a very, very bad sign. It indicates a diffuse, almost large territory of myocardial ischemia causing generalized conduction slowing. This patient collapsed within a few seconds, was resuscitated, and after resuscitation, when he was revived, his QRS became normal in terms of width, but the ST segment depression persisted. And this was the 12-lead ECG, which showed significant ST depressions which are downsloping, but remember AVR showed ST elevation and lead V1 also showed you a coving ST segment. He was taken to the cardiac cath lab where the angiogram showed this is the left coronary catheter, this is the aortic wall, and that's the origin of the left main coronary artery showing a pinpoint stenosis of the left main coronary artery. So the point to make is even this patient in the absence of pain can have a normal ECG. And this pattern of an impending left main occlusion is often wrongly diagnosed as non-ST elevation MI, which I just showed you in the ECG after resuscitation. Only AVR showed you ST elevation. Why is that? When you have impending left main occlusion, you have a large area of ischemia and the major vector points to the base of the heart causing elevation only in AVR, whereas your chest leads and even lead 2, 3 and AVF may only show you ST depressions, and this has been well documented over the years. What's not so well recognized is this pattern. Of course, clearly this patient during chest pain has broad symmetrical T inversion. Usually T inversions are narrow, but here I use the term broad because along with the T inversion, what you find is a gross QT prolongation. If you measure the QT interval, even at this heart rate, which is around 90, even there you find that the QT interval is almost 0.5 or 500 milliseconds. In fact, if you look at some studies of QT prolongation in acute ischemia, actually in all patients with transmural ischemia, in all these patients the QT was found to prolong. The only thing is clinically, if you have only one ECG in front of you, and the prolongation may not be that much, as I showed in this case, it's only when you compare it after ischemia, you realize that the QT had prolonged, and actually it's the earliest ECG abnormality, even preceding ST segment elevation or depression. This patient that I showed you, when the angina settled after 2 days, the T wave inversions disappeared, and the QT disappeared or became much less, but the QT interval became completely normal. And angiographically was found to have multivessel disease in the form of a circumflex stenosis and a critical right coronary artery stenosis. The other pattern that I told you is symmetrical T inversion in the precordial leads. So here if you find symmetrically inverted T waves, which is a classical pattern described in the stenosis of a proximal left anterior descending artery. And they were described by Diswan. So in Europe they are called in fact Diswan's T waves, or they are also called as Wellen syndrome. Paradoxically, when this patient has pain, the T waves become positive, and when the pain disappears, the T waves invert. In this particular patient, the angiogram showed a near total occlusion of the proximal left anterior descending artery. So remember this pattern, and remember that you could have during pain a nearly normal looking ECG. So we can get a lot of information from the ECG, which helps us when we clinically correlate, but most important, can we identify the high risk patient? There are many criteria for high risk in acute MI, and apart from the ECG, of course, we talk of the CLIP class, we talk of arrhythmias, especially late arrhythmias, we talk about age of the patient. But on the ECG, there are two issues. One is a large MI. Obviously, the larger the MI, the higher the risk. And second is what you call as very, very severe ischemia, grade 3 ischemia. So in anterior wall MI, a proximal occlusion of the left anterior descending artery will be a large MI. So that's the high risk patient. So can we diagnose a proximal total occlusion? So far I showed you unstable angina. Now we're talking about full-blown ST elevation MI. Can we diagnose proximal occlusion? Answer is yes. But interestingly, we can diagnose it not from the chest leads, but from the limb leads. How is that? If we look at all LAD occlusions, almost half of them are proximal. And if we look at a proximal LAD occlusion, and this is the left ventricle, that's the left anterior descending artery, and that's the right ventricle, the septal and the diagonal, cartoon, showing that in a proximal LAD occlusion, the infarct vector will point to the base, because there is much more myocardial mass at the base. So although the infarct process involves the entire anterior surface of the left ventricle all the way to the apex and even the apico-inferior region, even if it's a wraparound LAD, still the ST elevation vector will point to the base, giving you ST elevation in AVR and sometimes in AVL. On the other hand, the lead facing the inferior surface of the heart, like AVF, will show you ST depression. And exactly opposite is the distal LAD occlusion, where AVF will show you ST elevation, because now the base is spared and the infarct vector now points towards the apex and the apico-inferior area. So if you look at this patient who has chest pain since 1 hour, what you can see is there is not only gross ST elevation, so it's an anterior wall myocardial infarction, there's no doubt, but there is also a right bundle branch block pattern. There's a right bundle branch block, maybe an incomplete right bundle branch block, but an RBBB pattern and a left axis deviation. So the very presence of a right bundle branch block is another sign of a proximal occlusion of the left anterior descending artery. And this was the patient's angiogram. The left anterior descending artery was totally occluded before the septal, and you can see how large in caliber and how long it was when flow was restored by angioplasty. Sometimes you have to be aware of changing patterns and try to correlate with changing hemodynamics, changing clinical pictures. So this was a doctor who came with chest pain for 2 hours and clearly shows you ST elevation in V2 to V4. So it's an anterior wall myocardial infarction. But if we look at the lead AVL and AVR, neither of them show you ST elevation, but lead AVF actually shows you ST elevation. So here we should diagnose this as an anterior wall myocardial infarction, but a non-proximal LAD occlusion. What happened to this doctor? He was given streptokinase. This was several years ago when TPA was not yet introduced. He was given streptokinase. He worsened. He went into frank cardiogenic shock, and the ECG actually remained similar in the chest leads, but completely changed in the limb leads. So still it's an anterior wall myocardial infarction, but now it's the pattern of a proximal LAD occlusion. It's a proximal LAD occlusion. And therefore, what must have happened was that the thrombus, which started in the distal LAD, must have propagated proximally, and the pattern changed, the patient worsened, although ST elevation in the limb leads disappeared in the lead 2, 3 and AVF. So my corollary to this is, my take on this is, when you see anterior wall MI, look at AVF. If there's ST elevation, you're better off. If there's ST depression, you're worse off. And this was the picture in this doctor. So there was thrombus extending all the way from the proximal down to the mid LAD. So occlusion must have started here and propagated proximally. To summarize, the high risk patient in anterior wall MI, even if one of these ECG signs are present, you can take it that it's high risk, because all of them are specific, although individually they may be less sensitive. So gross ST elevation in V1, ST elevation in the orphan lead, right bundle branch block, and ST depression in lead AVF. In inferior wall MI, we know that patients who have right ventricular MI are at higher risk because it's a proximal occlusion, and we all know how to diagnose right ventricular MI. However, remember that lead V4R has to be recorded pretty early because these signs disappear within a couple of hours of chest pain. So if you diagnose right ventricular MI, surely you're talking of a high-risk patient. In addition to that, sometimes the right coronary artery is huge and it can cause cardiogenic shock because of myocardial failure. That's when we say it's a super dominant right coronary artery. And can we recognize this pattern from the ECG? So if you see a patient who has an inferior wall MI, due to right coronary artery occlusion, which we diagnose, there is right ventricular MI, so we know it's proximal, and on top of that you have gross ST elevation in V5 and V6, then this is a very high-risk patient. Because then you're talking of a super dominant occlusion, a proximal right coronary artery occlusion, which is super dominant. What about this reciprocal changes? I think the term reciprocal changes should be used only for inferior wall myocardial infarction. Do not use the term reciprocal changes in anterior wall infarction, because in anterior wall infarction they have a totally different diagnostic utility, as I showed you. But in inferior wall MI, lead V1 to V3, which is 90 degrees away from the inferior wall, can show you reciprocal changes. But the moment you talk about lead V4 to V6, just conceptualize the lateral wall and the anatomy of the heart. The inferior wall continues into the lateral wall. The right coronary artery supplies the inferior and then the lateral wall. So you cannot have ST elevation in AVF and ST depression in V4, V5, V6. If you get ST depression in V4, V5, V6, there is additional problem. There's additional problem. And in inferior wall MI, if you get this pattern, it's a poor prognosis. So if we look at this man who has clearly a proximal right coronary artery occlusion because there is a right ventricular infarction, what we see is V4 to V6 shows you a lot of ST depression. So this is a high-risk patient, very likely to have multivessel disease, and that's what it showed, right coronary artery occlusion, left-sided occlusion. To conclude, the ECG is still pivotal for the diagnosis of ACS, especially acute MI.